Well, welcome everyone to today's webinar on less frustration and more revenue, how hospital leaders are confronting denials with technology. My name is Jacob Emerson. I'm Associate News Director in the Becker's newsroom. And on behalf of all of us here at Becker's, thank you so much for taking the time to be with us today. Now, before we begin, I'll walk through a few quick housekeeping instructions for our audience. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording at any time. And if at any time you have trouble with the audio, try refreshing your browser first. You can also submit any technical questions into the Q&A box. We are here to help at any time. So with that, I'm thrilled today to be joined by a fantastic group of panelists from all over the country who I'm hoping can go around, introduce themselves for us, and share a little bit more about their roles and their organizations. So Jim, can you kick us off?
Yeah, I can. Thanks for having us. I'm Jim Bonesock. I'm the Chief Strategy Officer for Asperian, and the organization is focused on helping our provider clients collect the most complex claims and resolve those claims that are facing them in the market. So everything from denials to MVA, workers' comp, third-party liability, VA, out-of-state Medicaid. Been in the space 25 plus years, and I've got responsibility broadly for our strategy, our M&A function, and product. So how are we using technology to enable the resolution of these claims for our provider clients?
Fantastic. Chris, I'll come to you next.
Sure. So I am Chris Seymour. I am the Director of Transformation and Project Management Operations for Wellstar Healthcare System here in Georgia. We are about 11 hospitals, soon to be 12, made up of everything from medical offices to cancer centers, rehabilitation, hospice, you name it, we have it. Been in revenue cycle for about 15 years, and that is from scheduling appointments on the phone and moving into different roles throughout the revenue cycle, so very familiar with it. We are currently focused on making sure that denials that are coming through to Wellstar are being processed in a way that is most efficient, and looking at it from as many different approaches as possible, whether it's conversations with the payers, making sure our contracts are written out appropriately, to just a simple basic of working accounts that are coming through. So it is something that is very pertinent in our conversations in our day-to-day lives.
Sheila, I'll come to you next.
Yeah, I'm Sheila Augustine, Director of Revenue Cycle at Nebraska Medicine, located in Omaha, Nebraska. We have 2 hospitals, between both hospitals, about 855 beds, cancer center as well, trauma center, you name. Chris named it all, so we probably have the same. Been in revenue cycle for about 18 years. Started actually as the secretary in patient financial services and told myself that I wanted to be a director. Denials are probably my most favorite thing to deal with. We don't like them, but I like to appeal them, and I like to push the payers' buttons, so we can get into that more.
Perfect. I'm sure it'll be a fun conversation. Jason, I'll come to you next.
Thank you for having me. Jason Kane, I'm the Vice President of Revenue Cycle for Jefferson Health. We are located in southeastern Pennsylvania, Metro Philadelphia area, South Jersey as well. 18 hospitals, 3 physician groups made up of about 4,600 credentialed physicians, 50 plus outpatient and urgent care locations. We're looking at a hospital revenue of about $6.5 billion right now. And I've been in revenue cycle for almost 25 years. Spent about 15 years on the vendor side, doing insurance follow-up, self-pay stuff, and I've been with Jefferson now for a little over 8 years. Started there as the cash manager and worked my way through all facets of the revenue cycle to get where I am now. So like everyone on this call, we're dealing with denials at an unprecedented rate. It's a fun part of my job because it allows me to really get into strategy, which I love to do, focusing on different and innovative ways that we can mitigate denials and overturn denials. So we've had fun with it, even though it hasn't been fun, if you know what I mean.
And Sheldon, I'll come to you last to finish us off here.
Sure. So Sheldon Ping, I've been in revenue cycle for, I would say, around 20 years. I started as a file clerk in the business office and pretty much worked my way up through the ranks, serving as a chief revenue cycle officer, SVP of Rev Cycle, corporate director of Rev Cycle for various different organizations. I even spent a year in Abu Dhabi helping them building their revenue cycle because they decided to adopt the US reimbursement system, but didn't have a revenue cycle to support it. So kind of been all over. In regards to denials, one of the things that I realized is that once we build a robust denials management process, one of my keys now is how do we help operations understand what's happening on the payer front? Because I think I get a lot more traction working with operations and letting them see the trends and understanding where we're getting denied and for what than trying to overcome denials with payers. There are legitimate reasons that we can't overturn denials just from an appeal standpoint. But I think ultimately it's really partnering with different areas of the organization and helping them come together so we're fighting it together and it's not a CBO fight.
Yeah, no, it's a great point, Sheldon. And I do want to dive into all of that on how this is a multifaceted issue to attack. But let's start off pretty broadly by talking a little bit about what Jason mentioned, the unprecedented rates of claims denials right now, tensions growing among most health systems and insurers all over the country. So Jason, if you don't mind starting us off and diving in a little bit deeper about that, how this trend has impacted Jefferson Health and what are some of the key challenges, how you describe them in terms of what you're facing right now.
Yeah, absolutely. I mean, I think it's impacted us just as it has impacted everybody. I don't think in the space of denials, anyone has been really different. Here where we're located in the Mid-Atlantic, almost the northeastern area, we're, second, close first in the number of denials received from a, healthcare standpoint. And, it's been detrimental to us from a revenue perspective. Obviously, we're seeing reduced, but the hardest part, we're all trying to bounce back from COVID, right? So it's really prohibited us from getting out of that hole quicker than we thought that we were going to be able to. So on top of the whole COVID pandemic, denials continue to increase. So, not because of the pandemic per se, but because of the payer behavior and payer policy changes and everything that they like to do on a regular basis. We've had to fight increased administrative costs to work the denials and try to overturn them. Looking at from a strategy perspective, how do we allocate our resources? It seems like it's a day-to-day or week-to-week thing when we're talking about denials right now, as they come in waves. We've had to strategically increase our outsourcing to our vendor partners to try and handle some of the volumes that are coming in. The ROI on doing some of this work is, not positive in a lot of cases. So we've lucky enough to have some great vendor partners where we've been able to really strategize and create that great relationship to help in that area. And then we have patient satisfaction. When you think about the number of denials that we receive and how quickly you have to get through to them, right? It affects everything. It affects the timeliness of patient billing, right? We have to make sure that we're working our denials thoroughly to ensure that the patient is getting the correct billed amount to them, or that ends up falling into a patient experience issue. And then there's other operational challenges to process improvement and training. So we're constantly looking at this and how can we make our system work better for us? Here at Jefferson, we're operating on 2 systems right now. We have Epic on 15 of our hospitals, and then we have Cerner on 3 of our hospitals. So when we're talking about process improvement, it's different, right? We can't just put out a uniform, mandate to change something here. The system has to be aligned with that. And then training. We've had to really invest in our training department and internal training practices to make sure that we're keeping up with the payers and that our people are educated enough to know what to do, when to do, and how to do it. So, it's been a journey, but I think it's been a good one to really revamp some of our processes, and it's led into a lot of other positive things. I think somebody mentioned it earlier. Our provider-payer relationship, because of these denials, in a lot of cases, it's been contentious, right? As we open up our contracts and try to renegotiate, when we're bringing all of our issues to the table, that conversation piece during a negotiation is not the best for either side. We've done some strategic things with appeals to where some of our payer partners are seeing appeals at an increased rate, and we're actually getting calls. Hey, we can't keep up with your volume of appeals. What's going on? And we're like, yes, then our job is working, right? But then that makes our relationship a little bit more contentious at the negotiating table. So a lot of things to juggle when it comes to denials.
Well, I appreciate you taking us through that, Jason. And Sheila, I see you nodding along to a lot of that. So talk to us broadly about what you're kind of seeing with your payer relationships right now. I assume getting more contentious and how you're navigating that.
Yeah. So, one thing I would point out that Jason touched on too is, as we're coming out of COVID and looking at just the rate that we're getting denials, and I'm sure like the rest of you all, just staffing alone to keep people in the office, and just give them back the educations when you have a new person start. I mean, it's completely changed that people leave within a year. And so you kind of invested a lot into them. And so you can't even keep up with the rate of denials. But to talk about like the partnerships, I've always had my strongest relationship with United Healthcare. Doesn't mean I like how they pay. It doesn't mean I like how they deny, but it's very important to have that relationship because I want to be able to show and demonstrate like this is a working relationship for both sides, for the patient. We're here solely for the patient. And so we've got to collaborate together and work on how we can decrease those denials. But similar to like what Jason said is if we inundate them, they're going to feel the same pain that we feel as well, having to go through those things. Some of the processes are just so antiquated with some of the payers as well. You still have to fax, you have to mail, you can't do things automated, which limits your ability to then move your billing office solely from home, especially if you have to mail.
Yeah, no, it's a great point that there are physical limitations with how you can appeal some of these things. Chris, would love your thoughts here as well, how you're navigating this issue and ultimately how Wellstar is being impacted right now.
I have to echo the things that I'm hearing already. It is, the processes that we have to deal with and go through. Even, when Sheila was talking, I was thinking about it's not just the back end where you're reprocessing denials and what that fax and those processes look like. It's also the front end, even from an authorization standpoint, from, how do you have those communications that actually get you to the denial on the back end? Those processes with the payer have not been optimized with some of these payers and create even further gaps. People don't have time to sit on the phone. So it trickles down the revenue cycle resulting into a denial that impacts our patient. And I think a lot of the issues that we're having, I think, are a result of the changes that Jason spoke to that happen on a very regular basis and you can't keep up. Or even things where we thought we had it, and as soon as you think you have the hang of it, it turns into something else. And the way to keep up with that, essentially, is the analytics once the denial comes in, a lot of times, unfortunately, where you're having to figure out what the problem is, identify what the trend is, and then move that forward. And whether that is a change in the way you process it in your system, your scrubber, all of those things then become more work when you're already in kind of I don't want to say a downward slide, but you're already getting backed up from having to work the denials themselves. So it compounds the issue. And it does become a lot on your people. I think one of the things that we have done well, that I will say, is there's been collaboration between some of those teams. So whether it be a denial that is a result of the front end or somewhere in the middle of the revenue cycle, there's a lot of conversations that are happening now, which are helping to decrease that from happening, and to figure out what is happening in that collaboration and in those conversations so that we can make the process a lot more efficient than what it has been, and then start to cut away at what those denials are. So it's a process, but it's one that we have taken as all inclusive, not just SBO or someone has to work it on the back end, even if it's AR, it's a conversation that I think has improved a lot of what has happened in the process, not just for us, but for our patients as well.
It seems like two important points that I've heard from a few of you now, though, too, is that this trend is really burdening your staff, your employees a lot, which I understand can be very difficult to find in your departments. But it also sounds like the strategies you employ need to also not overwhelm the payers to work in a true partnership. Sheldon, I know you started us off by talking a little bit about how you're bringing in your operations staff to help tackle this problem as well. Can you dive deeper a little bit into that and other best practices or tools and resources you found to have proven effective on this issue?
Sure. So one of the things that I've always tried to purport to the team is efficacy by efficiency. And for us to do that, right, we have to involve the appropriate parties. And what I noticed that in the back end, there's a lot of things that we can't figure out. The payers only have one avenue, is to deny. That's how they delay. So when we're having staffing issues and they're having staffing issues, they're going to increase denials to delay payment because they can't even get to it, right? But what we need to do is really focus on, let's look at the trend on where they're denying, why they're denying, what frivolous excuse are they making up to why they can't pay a claim, and then hold them accountable for it. Using those JOCs, we need to make it more targeted. So what I've noticed is that in the past, people will go to JOC and they'll have 200 issues written down. Let's focus on the 4 issues that we have data to support, right? These 4 issues, we noticed that for these 20 claims, you did X, and you focus on it like that, because you're not going to get anywhere just throwing spaghetti at the wall, for lack of a better term. The other piece to it is, especially with the staffing, we have to start looking at some form of automation. I'm sure everybody on the call experienced a huge increase in ADR denials, right? And it's like, okay, guys, how are we going to handle this? Are they going to stop it? No. So how do we figure out a way? Can we automate pieces of the process to free up others to do more relevant work to support it? And the challenge that the payers are slick with is that some of these ADR requests are truly, when you give them the medical record, they expect an appeal, but they didn't tell you that. So now that was your first, you sending them back that medical record doesn't really count because it had to have an appeal with it. So you can't automate every piece of the process, but there may be some part of it that can be automated and actually reviewed prior to sending out medical records. And then I think lastly, the biggest thing is, even though I said we work with operations a lot, but I think it's also changing the mindset of the organization. Denials is an organizational responsibility, not a PFS responsibility, right? There's a large piece of the process that happens from the front end, the clinical care, and going back. And from a CBO perspective, we don't take care of patients, right? So we have to really help the physicians and not the physician, but the clinical team, and help project manage them through the nuances that the payers are giving us today.
So, Jim, I see you smiling through a lot of that. Would love your thoughts here on system-wide across the country, how you're finding that health systems most often are addressing these denials, and if you're finding any best practices are most common or proving the most effective across the country.
No, I appreciate the comments. I mean, it's echoing what we're seeing across the 1,000+ hospitals we serve today, and it's not, as we've seen it, like increase in denials, yes, but it's not like we all of a sudden saw an increase in front end technical denials where we messed up the registration, or we didn't verify the insurance, or those things have always been there, and there's no, I would say, new rules that have been implemented to cause those to increase. It's the compounding effect of staffing, right? And the inability for us to staff back to levels pre-COVID, to train that staff and retain that staff so they're slightly less efficient, so more error prone because you got someone new at the reg desk in the ED at midnight, those kind of things. But what we're seeing more often that's causing a bigger problem is the high dollar complex denials that take clinical validation. So they require the medical record. They're everything from DRG downgrades to patient type downgrades. Those types of denials where I have to pull the medical record, I have to compare it to, I have to pull out the clinical evidence that this meets the criteria as dictated by Milliman or even the payer themselves, and then justify, as Sheldon said, through an appeal process that, oh, I should have been paid this reimbursement rate, or it should be an inpatient stay, or whatever those things are. So Aspirion luckily has been doing that for a long period of time. We've got over 150 attorneys and 65 clinicians that are all focused on just doing that. But as we even, and so our partners are looking for us to plug those holes, because those denials themselves are not just throw, more PFS staff at it. It's, I need a certified coder. I need a clinician to review these medical records. I need somebody more specialized to write this appeal letter to overturn this. And so that's where we are seeing increased volume of people turning to folks like us to plug those gaps, to fill in those specialized needs of expertise, if you will, to pull that medical record, to write that appeal letter, to get those overturned. And I think that's, a combination of investment, and these payers are deploying technology at a pace that we as provider community are not deploying it. We're not geared to deploy it that way. We don't have the capital to deploy it that way. But these payment integrity initiatives that they're being broadly characterized as are allowing them to put rules in place at a rate we've never seen, and to really target and focus on those things, again, that take, it's one of those deny it out of hand and then prove it to me by pulling the medical record and pulling out the evidence and showing me and doing an appeal letter. And that's a lot of burden on the provider community to be able to overturn those things, right? It's not just correcting the patient ID. It's not just updating the date of birth or, getting a member match. Those are not the types that we're seeing as much as these, again, ones that take a massive amount of resource and specialized resources, expensive resources at that, to deal with them. And so it's putting a lot of pressure when you can't staff anyway. We've got challenges there broadly in the market. We've got wages going up. We've got all of those things impacting us on top of, and then you pile this on top. So we're seeing it, kind of across the board.
I think Jim and Sheldon both kind of touched on this. And if you go back like 5 to 7 years and writing an appeal, I could sign my name to that, and it goes to their medical director. I'm sure that they were like, who is this person? What credentials do they have? Now it's almost like it's a must to have with the clinical denials that you're seeing, which I think, Jim, you touched on that. And you're going to pay a lot more for that, whether you have physician advisors that help to do that, you have LPNs, RNs that are helping to write that. Whereas previous, we could write that, staff could write that, you could go copy some stuff from the medical record and, let's be honest, act like you know what you're talking about a little bit. But it's just that whole dynamic has just continued to change.
And Jim mentioned
Jason.
something as well. I'm sorry, Jim mentioned something as well with the Milliman and Intercall. One of the things that has been real successful for us over the last year is establishing the fact to our clinicians that Intercall and Milliman are guidelines, right? And they really have to start focusing more on their documentation, right? And not necessarily focusing on Intercall and Milliman. Because now, to Sheila's point, we would say, if I was writing an appeal, I'd say, meets Intercall criteria. But that's not flying anymore. They want to get a lot deeper. They have to pull back the onion. I'm not a clinician, nor is anybody on my team. So once you start changing that organizational behavior to start saying, we need to focus more on documentation, because the payers are going to deny. And one of the things that we always look at before I even appeal the denial, actually, let me step back. The denial appeal process is in the back office. But what we also try to do is get feedback and say, yeah, we knew we were right, but what could we have done? What is that extra step that we could have done to even prevent the initial denial? What wasn't there, right? What could be more clearer in the record, and things like that, and then use those as performance improvement opportunities throughout the organization.
Jason, Chris, I want to make sure you guys have ample opportunity to respond to the other panelists. Anything you'd add off of what was just said?
Yeah, I mean, Sheila brought up a good point with the clinical appeals. That was an area in which Jefferson was struggling because our utilization management areas were so pressed, for dealing with continuity of care and appropriateness of care. So that's an area where we had to strategize and figure out how could we, how could we fix this and how could we better support the organization. So coming up with a vendor partnership opportunity doing some different things with the appeals, making sure that we're a lot more thorough, as Sheila mentioned, and getting, lawyers and attorneys involved in what we're reviewing and submitting those appeals. Not only that, but the volume that the vendor partners were able to do was far and beyond what we were able to do. So it really takes a lot of the stress off of our internal utilization management team, allows them to focus on getting things better up front so we can try to start to mitigate those appeals. So it's really strategy that's been helping us, and that's where we've been placing our focus.
Chris, how about you?
I think Sheldon said it best. It is a component of making sure you're understanding what happened to result in those denials so that you can stop those same ones from coming in and or, apply that across the board, because there's no point in having that information and not doing anything with it, but also carving out the time in order to do that is vital in order to decrease at least some component of the denials that we're having to work and engage with. So I think that is an opportunity that we try to look for as much as possible, is where did we go wrong and how much are we impacting, whether that be through claims count itself or through actual dollars.
So I do want to switch gears here for a second and touch on something that Jim had mentioned, that payers, this is a time where payers are increasingly putting in new policies, new rules at an unprecedented rate that it is incredibly difficult to keep up with in terms of submitting claims. And so from our own reporting here at Becker's, we found that more than 70% of hospital and health system financial leaders like yourselves are considering applying artificial intelligence to their revenue cycle processes. So, Chris, what is that? How does that align with Wellstar? And if so, have you seen or are you expecting to see an improvement in denials using AI-powered tools? Take us through where you're currently at.
So I think right now we're trying to understand exactly what those options and opportunities are, if for no other reason. But I think AI and artificial intelligence is thrown around a lot as a word, and it's almost like the new trigger word for people. And it is not a bot. It's not, fixing your system to do something automatically. It is truly is something learning to then take those steps that it needs to the next time it sees those patterns of denials, however along that set, that they're actually learning how to address those, whether it be through your scrubber or through some type of kickback. And I think that's kind of where we are, is trying to identify the right tool that is going to provide, opportunities versus create more work. And, as I said, I feel like AI is just kind of all over the place and people don't understand exactly how to use it or how it applies. So from a Wellstar perspective, identification of the right vendor, the right solution is where we are. We're too large to pick something or, throw, as Sheldon said, throw spaghetti at the wall and see if it sticks. To even attempt to approach it lightly. So I think that's where we are. Really looking and excited for the opportunities of something learning. This is something I've seen multiple times. Now I can fix it without us having to manually go in or allocate those FTEs in order to do that. Because, essentially we don't have the time, as everyone has already stated, where staffing is already a complicated issue in itself. So, anything that relieves that is something that we're excited about and very interested to know more about.
And it's a great point that you make, Chris, that the language around AI is truly all over the place right now, certainly within the media. But that being said, Sheldon, I do want to come to you and ask, regardless, do new AI tools align with some of the work you're doing around revenue cycle processes?
It does, but I think going into it, you have to have a clear understanding between RPA, machine learning, and AI, right? There's a large umbrella where they call automation. And again, these terms are used synonymously, but they're not. For a good RPA process, I still need an individual that's going to monitor it, because without that, the process breaks and then it'll cause me more harm than it did good. I mentioned earlier about an ADR process that requires an appeal. If I did an RPA for that and automatically send a medical record, it's actually hurting me because I didn't capture it. Machine learning. That's good if your organization can support it. If there's enough data or historic data to say, here's what we see the payers are doing. The challenge with using machine learning in today's environment is that the environment has just changed. we may not have enough, and we may not have enough information to understand what that change is for us to implement something that we can quote unquote machine learn from. And then AI becomes a lot more intuitive, where you don't need just my organization. I need to understand what United Healthcare and Blue Cross is doing at every hospital within healthcare to truly understand how I can predict the future of their behavior. Now, that all being said, there is value, right? But it's just how you can implement it in your organization. Everybody's hospital has their own DNA. And that is the strength of your IT team, the strength of your internal team, your budget to support what kind of tool that you can actually purchase. And I think when you put all of that together, you can come up with a solution that would help and advance, the denial management or denial prevention initiatives within the organization. But it's just truly understanding what your need is and where you can apply it in your organizational resources.
Sheila, what would you add here?
Yeah, I'd echo both Chris and Sheldon. I was trying not to laugh when Chris was talking because I think that all the terms that we use are just synonymous with each other. I remember when they came out, I was like, what's the difference between them? Because I didn't know. And then as you get into the nitty gritty, then you start to find it out. But I think that we are slow adopters here as well. And it goes back to Sheldon's point of having like a strong IT team, the people that can build that out for you. So you really have to take essentially what you can get, see where there's some value. Just for example, we moved to doing automated authorizations. But again, to Sheldon's point, somebody still has to click a button to do something. So, is it fully automated? Do we use that? Is it a robotic process? But I think overall healthcare, we're behind the scenes with a lot of this automation too. And we are not very fast adopters, which is why you do need to leverage some business partners that maybe do have the technology that you can't build out. And I know Jason said he was on Epic and Cerner, we're on Epic as well. Epic doesn't do everything for you. I mean, ideally, you paid a lot of money for it. It doesn't do everything. And so that's why you have to augment where you can.
So Jason, do you agree with that, that generally the industry is pretty far behind? And how would you sum up what's going on at Jefferson right now?
A great question. And I kind of chuckled a little bit because I thought we were so far behind at Jefferson and almost to the point where we were panicking. We tried to be earlier adopters of this and went through a full-scale implementation of, we'll just say in general, automation just prior to the pandemic and throughout the first year to year and a half of the pandemic. But I'm going to proudly say that we failed. And I say proudly because it was a great learning experience for us. That failure of that allowed us to realize that we need to take a step back, reassess the whole situation, and then approach it a little bit differently. We took a year off talking about it, thinking about it, and then we came back to the table. And just like Chris said, who's going to be our best partner to do this with? What is going to be the best technology that we want to do? What is going to be our approach? So now we're in our second attempt to do it now. It was one of my top 5 operational initiatives for this fiscal year. And the approach has been way different than we did before. You need to take into consideration everything that you have, not just the bot technology, RPA technology, but what can your system do? I know we said Epic can't do everything, but Epic can do a lot. And if you're creative and innovative, Epic can do even more, right? So thinking about that, first and foremost, what do you have in your shop right now that you can just put into action at a low cost to get a high win? And then when you're looking at the AI implementation that we're looking at, the hardest thing I found to be was not the IS&T support, was not the maintaining or anything. It was actually finding the right opportunities for process automation. Having the team sit down and, shadowing people for 8 hours a day, looking at what are you doing, what redundant tasks are you doing all day? Shifting from a let's reduce FTE cost perspective to let's reduce FTE touches, right? We don't want to get rid of people. We want to put them on the more important things. We want them to maybe do what they're doing now, but maybe we can do it in less steps, right? If it's taking you 7 touches to do a full appeal right now. How can we get down to 3 so you can move on and look at another account? So it's things like that that's really changed our approach to this, and we've been a lot slower, which, as frustrating as it is, we have to look at it and say, okay, this is the right pace. So we're doing a lot of things. We're moving on to phase 2 of our restart now, where we're getting into more complicated things. We went live with the NOAs and authorizations in certain areas. We've been up on claim status for all of our major payers. Now we're moving into additional documentation denials. How can we automate a lot of those requests? We're moving into our complex denials. How can we start triaging them before we get the explanation of benefits and getting them in front of the right departments for feedback, so that way we're ready to begin our appeal process day 1. So there's a lot of more complex things that we're getting into now, which I'm excited about, but also a little nervous, because we want to make sure we do it right and not lose the momentum that we've had thus far.
Well,
So Jim, hearing that, oh, sorry, go ahead, Sheldon.
Nothing. Let me start by saying, for every health system that's on this call, right, your health systems have done amazing work in regards to providing healthcare. And I think what has changed over the last 2 or 3 years is that the business of healthcare has changed, right? Our organizations were focused on giving care, right? And then now what they told us to focus on is consumerism and automation and things that we've never done before. Because I'm sure when we Google our organizations, all of us have the newest tool to provide the best cancer care, the best heart surgery, and that's what we've invested in, because that has been what society is expected from us. And then over the last 2 or 3 years, they changed and said, we want you to be more like an Amazon or Google or whatever like that. And healthcare does move slow because our margins are a lot slimmer, right? We don't have health systems that are making, $100 million and could say, you know what, let's just reinvest $20 million in X. We're looking at that 2% margin and we're trying to say, how do we now invest in healthcare and also invest in what society is saying they want now in regards to automation and all of this innovation. So I think that, we got to pat ourselves on the back as well, because as the revenue cycle leaders, we're learning how to adapt to that. We're changing up our budgets. We're trying to figure out how we can meet society needs with also meeting the core fundamental of what a health system is supposed to provide.
And I
That's
think
a really
that's a
great point.
component of like what Jason said is finding the right process. You can't just throw AI or automation or a bot at anything. It's identifying the right process. And then second step, making sure the process that you already have in place isn't broken. Because if you're trying to apply automation or AI or anything to something that's already broken, it's just going to set you back even further, and then also disengage your team members from even utilizing it. And you're going to have a loss of trust, which sets you back even further. So I think that's like a very key point to point out, is what is the right process to apply this technology so that it is effective and you can optimize whatever your process is.
So Jim, on the wider scale, how are systems having these conversations about what is the right process? Where is the right area to be bringing in these technologies? What are you seeing?
Yeah, I laugh. Chris is so right. The buzzword bingo, it was big data in the cloud, whatever, 5-10 years ago, put up a booth at HIMSS. Now it's RPA, AI, right? That's machine learning. Let's put up another booth at HIMSS. They do get overused, and I think it is very important. Everybody made great points about, identifying exactly what are we talking about? What is the technology where we're trying to automate. So we're trying to lessen the need for humans to do some task can be repeatable and done by a system, not by a person. And for us, allow those people to work at the top of their license. It's like delivering care. How do you do that? How do you take the administrative part out of it, the repeatable part out of it, and begin to automate? And we've seen a number of cases of great technology and companies with the theoretic possible of we can automate that, and then they're missing a key component, which is access to data, right? So I can theoretically automate that, but I don't have access to data, and it's like the cart and the horse. man, I could automate it if somebody would give me the data. Well, I'm not going to give you the data because I think it's proprietary and or my process isn't fully defined or working. And then the third component is the subject matter expertise, those people who do the process, that produce the result and know where the automation opportunities lie and or can tune that automation to make it efficient. And so it takes all three of those components to do it and to do it well. And I would actually say, I believe it's on Esperion's back, because we think about this every day, to invest on behalf of our provider clients to make that process more efficient. Most provider clients don't have the budget, don't have the margin, don't have the capacity to go all of a sudden invest in this new technology and or build it. And so I think it's hard, and I think it's why we're, generally as a provider community slower to adopt, is because we got a lot of other things going on. I do have these new clinical devices that I got to get in place. I do have the threats of cybersecurity. I do have all of these, other fronts that I'm fighting from an IT perspective, and it's not just revenue cycle. So back to that, I think Esperion in particular made an acquisition in the fall of last year of a company called Infinia ML. And we did it because, again, we didn't have the full capabilities. They had built a platform. It had been born out of Duke, and it was 9 PhD data scientists and 12 machine learning engineers who had built a platform specific to parse unstructured data, structure it, load it into a platform like a large language model, ChatGPT, that most people know about, and then produce a generative output. And so as you guys think about, we get paid for a result on a contingency basis, overturn that appeal. Well, the majority of the work that our attorneys do, and the reason why it takes them a long time to work these cases, is I got to pull a medical record, which is unstructured data. I got to compare it to an unstructured contract, also data, right? And clinical guidelines. And I got to marry those three things up. And then I got to create evidence that says why we should be paid at a certain rate. And so perfect use case for us. I've got, like I said, 150 plus attorneys, and I've got 65 plus clinicians. So I've got the subject matter expertise. I've got the data from our 1,000 plus hospital clients. So I'm getting a lot of that, right? What I didn't have was the platform to automate that process. And so what we've got now is the ability to pull and index a 200-page medical record in, a couple of minutes, create a timeline, produce the evidence for the attorneys to review, and then begin to generate the appeal letter, right? All compared to clinical guidelines. So we're just trying to, again, human in the loop, automate a very specific process, as Sheldon said, like not everything. I'm trying to automate something to make those subject matter experts more efficient at their job and to begin to fine tune the model such that it produces an output that helps our provider clients, collect the dollars they deserve.
I think we've all kind of touched on it. When we start talking about artificial intelligence, robotic processes, you also have to be very careful when you're sharing that with your staff too, because they look at that as my job's going away. And as much as you can tell them, no, it's not, we're going to move your expertise to another area. So there's always another area, and you can do things by attrition over year after year, but making sure that staff feel comfortable, because it might not be as successful as you want it to be if your staff is very hesitant on it as well.
Well, and it doesn't seem to just be staff adoption issues that we hear from finance leaders in terms of their concerns with implementing some of these new tools, but it's also the accuracy and potential bias issues. It's the actual physical implementation, so on and so forth. I know I'm preaching to the choir right now. So Sheila, what barriers have come up beyond staff adoption for you, and how have you navigated those thus far?
Staffing was one of the biggest ones. I would say for us, unfortunately, probably just IT resources to help integrate into our systems. Just essentially it's getting if I signed a new contract tomorrow, it's getting that project through the whole piece, IT, risk, legal, and just implementation. And so that's really always a lot of times where I feel the barriers are. And it's not because somebody's doing it, it's just we all need resources, and you can't throw when I think Jason said it best, he had a top 5 initiatives. Well, everybody has a top 5. And so how do we all bide for our number one?
You want to weigh in there, Jason?
Yeah, the barriers they've been a little troubling. I mean, staff adoption, as Sheila said, that was a tough one initially, but as we brought the team into the know and taught them what we were going to do, here's the result, and they could see it, right? That's where they start to change their buy-in once they start to see it. But some of the other things that we struggle with, I mean, the ROI calculations, that's tough, right? Your CFO wants to know, how can I bottom line this? Like, what is the net effect? And trying to figure out that ROI. Everyone's got a secret sauce. Everyone's got a formula that they use. Whose is right? So we have to sit back and see what works for us and how it makes sense. And sometimes a lot of that is trial and error, right? Run it, do it. Let's see where the impact really is, and then you have to back into it. Scalability, flexibility, all the changes that we're seeing. I think Sheldon mentioned it earlier. All these changes are payer behavior changes, policy changes month to month. We're on Epic at a lot of our hospitals. Epic is doing an upgrade, it seems like every 30 days. So when you're talking about AI and screen scraping, you got to retrain the bots, make sure that they don't get caught offline. And data privacy, security, our compliance team is very heavy on that, making sure that they check, double check, triple check what is going on with that. But one of the things that I'm dealing with now, as I mentioned, we're on 2 systems. So 15 hospitals on Epic, 3 hospitals on Cerner. At the same time, we're trying to integrate all those hospitals into one operational model. We have a plan to bring the other 3 hospitals up on Epic over some time. So now when we think about automation, what's the case for implementing it with our legacy systems? How do we, scale it down to maybe a few? What are the most important ones? What do we need to do? So we're juggling with that now to try and keep consistency across the continuum of our revenue cycle, and balance out the cost there. So
I think
Well,
one
the
of
interest of, sorry, go ahead, Sheldon.
Sure, Sheila touched on one of the points about even working with IT. One of the challenges that I think the biggest obstacles is revenue cycle is operating in real time when everybody's operating in hindsight. And I think that's the challenge, right? Because IT typically would start and say, for the year, we're doing X amount of projects, here's the resources allocated to it, and so forth. And then we would have an issue in revenue cycle, say by March, exacerbates into something huge. And we say, hey, listen, there's this tool. We can implement this tool. It'll take 4 weeks to implement, but it'll erase this. Then IT goes, but where do you want us to do these 4 weeks? And I think that's always been the challenge. I mean, I've tried in many different organizations to try to build in some time where it's like, I don't have a project for you yet, but I have a project and I know it's coming. I don't know whether it's divesting of something, onboarding of something, but I need a placeholder. And that has helped me a lot in, helping to build a partnership with IT to just say, hey guys, we know that you're strapped. And because of that, I'm building in time for it because we do operate in real time and our needs shift very quickly.
Well, I do want to get us moving and towards a conclusion of more excitement or what you're looking forward to in this space. So, Chris, maybe you could start us off here and talking a little bit more about your predictions on the issues of what we were talking about today, widespread denials, and how you think that issue will continue to evolve, but then how health systems will continue to evolve their responses, including with advanced technologies in their RCM departments.
I do think artificial intelligence will be a tool that we will utilize a lot more, especially in the denial space. I think that it is something that will not only improve the overall patient experience because they won't have to wait so long in between whether they receive a bill, don't receive a bill, and things are getting paid. It'll also free up people to do the work that they need to do that requires them to work at the highest level of their certification, and that will empower them. That will improve our longevity when we're keeping people in our departments, and then overall result in a better experience for all of us holistically. I do feel like denials are going to continue on the same trends that they have because payers, well, they're going to continue to move the needle as often as they can and make changes as often as they can. And whether that is regulatory or because they felt like it today. we're going to have to continue to find ways to adapt to that and respond to that in ways that remove the burden from ourselves, our patients, and our people so that we can have a better process holistically.
Sheila, anything you'd add there?
I think Chris touched it very, very nicely. You know, we're gonna see more and more artificial intelligence. We definitely need resources to help us with it. Back to Sheldon's point, not trying to solve every issue. I'm really excited just to be able to possibly spit out an appeal letter that nobody had to type. You know, the computer over time can learn how to do that. But again, same thing as Chris, the denials aren't going to stop. They're just going to find a new way to look at it. And it's not, we could even say it's not even denials. It's just a delay in payment. I mean, even a clean claim that they don't need to deny does not pay in 7 days like it once used to. You're talking just 30 days. And so that's going to continue, and we're going to have to continue to look for ways to use our resources best.
How about you, Sheldon?
I'm looking forward to the evolution of what we're doing now. I think post-COVID, we've had more conversations with colleagues in regards to what they're dealing with in health systems and how they're handling it. And I'm looking forward to where RCM gets to a point where we have a roadmap that really can help us navigate payer issues, right? And it doesn't matter if you're in Nebraska or Atlanta, Philadelphia, it's just here's how you have to deal with a payer because we have started to stick together and share knowledge. So that's what I'm looking forward to, the evolution of it, you know, the growth. I want to see 10 more of us on this call and where we're talking about how to solve issues.
Yeah. Jason?
So something I'm not particularly excited for, but more of a prediction is, you know, just remembering that as we get more innovative in automation and AI and everything, the payers are doing the same thing. And they're developing the same type of things that we're doing to try and deny more. So that is going to be a back and forth battle that we're going to have for years and years to come. So in order to try and mitigate that, you know, the thing that I really want to shift my focus to is developing stronger partnerships with our payers. We've already started. 2 of our major payers have officially partnered with us for digital adoption of some processes. I'm super excited. We've been pushing them for 3 years now, pitching them on JOCs and all of our monthly escalation meetings. And we finally had 2 come to the table and say, yes, we'll partner with you on this. And we're starting some great things there. But that's going to be the future of this, right? Making sure we can work together because all we're doing now is competing, right? We make a better process, they figure out a better one, and it's back and forth. So we got to find a way to come to a happy medium.
Well, Jim, we've got just a few minutes left. Any final thoughts you'd like to share, not just with our panelists, but with all of their colleagues watching us?
Yeah, no, I think I like the way that Jason capped it off. It is an arms race at the end of the day. It's always been a bit of the Hatfields and McCoys. You know, we arm up with something, they turn around and do something else. And so to the degree you can bridge that and partner with those payers, share those insights, you know, see those patterns, that kind of thing. And as well, you know, I think the collective provider community, the reality is they're far better, payers are far better capitalized, you know, they're more consolidated, they can deploy technology faster than we can on the provider side. And so that challenge is going to continue to exist. I think that gap between the 2 organizations is widening. And so I do applaud, you know, I think it's incumbent folks that are provider centric and provider focused to develop and deploy these technologies. And again, I would push it to how do we look for an outcome? Whether I'm using automation, I'm using RPA, I'm using AI, I'm using ML, I throw your buzzword in there. Are you getting the outcome? Are you getting the claim paid? And you know how you're doing that. Don't care how the sausage is made. Certainly, if I can do it far more efficiently and I can retain those resources and I can do it at a clip that helps, you know, the provider clients meet their financial goals to provide better care and a better patient experience, then that's a good thing. And then again, I think we'll evolve over time to deploying that technology, you know, within the systems and allowing the technology itself to do the work. But for now, it's kind of human in the loop. How are we making our current processes more efficient and how are we working with our clients to kind of accelerate that and defend some of the bad behaviors that are happening on the other side.
Fantastic. Well, that is all the time that we have for today. So I want to thank our panelists for taking the time to be with us and for sharing their expertise with us. We truly appreciate it. I'd also like to thank Spirion for sponsoring today's webinar. To learn more about the content presented today, you can check out the resources section on your webinar console and fill out the post-webinar survey. On behalf of all of us at Becker's, we thank you for joining us this afternoon.